IPS Vadodara and Bombay Psychiatric Society for yet another session of Brain on Wednesdays. We are going to have the topic as on addictions. In 2 sessions, we'll be taking it. Today, it would be biological underpinnings of addictions. To chair this session, I invite Dr. Ajita Nayak, who is presently the professor and the head of the Department of Psychiatry at St. G.S. Medical College and KM Hospital. She has nearly 30 years of experience in the field and has risen up from grassroots to head the department, well-read academically and befitting to chair the session. Dr. Ajita, the platform is yours. Unmute yourself, Ajita.
Yes. Thank you, Dr. Rajkumar. It's a great pleasure and an honor to be chairing this session with such stalwarts here. And the topic is also so interesting, underpinning of addiction, biological underpinnings of addiction, especially as the speaker also is a well-known figure in this field. So I'm looking forward to this. I think it's a very pertinent topic, especially from the management of addictions, which we struggle with, all our patients. Because I think as history tells us, even in schizophrenia, till we really found out about dopamine, that was when the revolution of treatment took place. Otherwise, they were struggling with that too. And we are still struggling with addictions, with relapses. And it's quite difficult to put the patient back in society most of the times. So very relevant, very pertinent topic. And thank you, Dr. Rajkumar, for inviting me as chairperson. There are a lot of interesting questions, I think, related to biology of addiction. As why only some people get addicted when everyone is experimenting, or why only some drugs, which we call narcotics. We are all taking so many drugs. But why get addicted to only those drugs? So I hope Dr. Mohan talks about all this. And some things we know, I guess, genetics, we see the addictions running in family, or we've heard of, we've read about biological markers. So I'm sure he's going to give us all the recent trends and guide us towards managing these patients much better today. So just I have the honor also of introducing our speaker. He's a senior practicing psychiatrist from Chandigarh. He has done his MD from PGI, renowned institute, in 2000, and PGD MD from NLSUI, Bangalore. He's currently advisor of NDP, Committee of IPS, member of APSI, and secretary of Trichy Psychiatric Society. Of course, his main areas of interest we know, substance use, but I think forensic and law and advocacy also is excelling in. So a great honor to have you, Dr. Mohan, and
thank you, ma'am.
Over to you.
Thank you so much. So at the outset, I'd like to thank Dr. Rajkumar and all the BAU team for giving me this opportunity to discuss about biological underpinnings of addiction. And thank you, ma'am, for the kind words. Without much ado, I'd like to proceed with my presentation, with your permission. So I'll just share my screen. So I hope the audio visuals are clear.
Yes, it's clear. You can see.
Thank you so much.
Yeah.
So the topic given to me today is biological underpinnings of addiction. And as I said, I'd like to express my gratitude for inviting me today. I'll request everybody to mute their mics, please. Thank you. So what we'll be discussing today is about the biological basis of addiction, a little bit about neurotransmitters and circuits, and how the transition from simple casual use to compulsion occurs. But we will exclude, because it's a very broad topic, we'll exclude uh, discussing about individual mechanisms of drugs or their pharmacology. There are multiple drugs, opioids, alcohol, nicotine, stimulants, cannabinoids, psychedelics, and the list is very long. It's impossible to really discuss each and every drug and how they act. We'll also not be discussing about genetics and epigenetics. Of course, we know that addiction is quite a hereditable disorder, but again, this is beyond the scope of this talk. We'll also not be discussing about clinical issues such as mechanisms of tolerance and withdrawal, and of course, not about treatment or medications, at least not in this particular session. So I'm quite a simple man, and my brain itself is quite simple. So I'll be relying on some simple schematic diagrams. The neurobiology of addiction can be actually discussed as a three-stage cycle, which involves the binge. This is a very, very famous schematic diagram by Coop, who's done research for the last more than about 20 years or so. And it involves three stages of binge intoxication, a stage of withdrawal or negative affect, and a stage of preoccupation. And these stages are not isolated. They feed into each other and finally lead to a state of what we call as dependence. All of these three states involve multiple circuits inside the brain. Again, as we know, the brain is organs. I mean, the brain circuits don't work in isolation. There are functional, there are structural circuits, there are major circuits, there are minor circuits, there are micro circuits, nano circuits, and all of that. And there are multiple transmitters which modulate each other. But for our understanding, and this is very important because unless we understand what is happening, we won't be able to treat our patients better. So we have three stages: binge intoxication, negative affect or withdrawal, and the preoccupation stage. And of course, there are multiple neurocircuits and synaptic systems which are involved, and there are neuroadaptations which take place in each of these systems. I'll come to this diagram. I'll refer to this diagram later again for explanation. So if we zoom into some of this part, and we see there are, as I said, there are multiple different kinds of mini circuits which are involved, and I will be describing some of them in detail, but not all of them. So as I said, to recapitulate, there's a three-stage addiction cycle which involves binge intoxication, withdrawal or negative effect, and preoccupation or anticipation. These involve multiple neuroadaptations in three corresponding domains. That is increased incentive salience, and I'll be describing some of these terminologies later. Decreased reward, brain reward, and increased stress, and compromise executive function, respectively, in all of these three different stages. And they involve three major neurocircuits in the basal ganglia, the extended amygdala, and the prefrontal cortex. So just for simplicity, and for understanding, there's a three-stage addiction cycle framework in three corresponding domains involving three major neurocircuits. So how does addiction evolve over time? So we generally see in our patients that there is a simple casual use followed by heavy use, leading to early dependence, and finally the full-blown syndrome of dependence, where it's actually a neuroadaptive state. And in between, there are periods of abstinence, which may be weeks, days, months, or even years. But there is virtually no drug of abuse which is taken 365 days, 24/7 times in a day. And there are periods of abstinence in between, and this is what happens. What is also important to understand is that initially it's the impulsive stage. A person tends to take a drug impulsively, and it involves usually the binge intoxication stage, as I said earlier, and it is dopamine driven. Followed, when this stage occurs repeatedly, it leads to a compulsive stage, whereby it becomes an automatic action by the patient to continue to take the drug compulsively without even thinking about the consequences. So a stage of positive reinforcement, which is driven by reward, actually leads to a stage of negative reinforcement later on, which tends to drive the addiction. So as you can see, the early use is driven by reward, but the late use and the stage of dependence is actually driven by the negative reinforcement or the stress. Again, this is again a slightly different diagram. I wanted to emphasize what I said earlier is that if you look at this thing there on a background of individual genetic factors and life stressors. If you look at the initial stage, the reward is high, but in the blue color, but it tends to reduce, while the relief or negative reinforcement from a negative affective state tends to be low initially, but it tends to increase. And as the addictive process continues over time, and after periods of abstinence and periods of relapse, see this arrow which comes back, and the arrow comes back to the red sided area, not to the blue sided area. So it is not what reward which determines the continued drug use, but it tends to be the relief from the dysphoric state which the drug actually produces. So this is very important to understand. Many of our times when we talk to our patients, we say कि वो तो मजे के लिए ले रहा है, हमेशा उसको और कोई काम नहीं है उसका, he does not really want to leave it, but we fail to understand and actually comprehend that many of the times it is the relief factor which is extremely important. So again, this is another diagram which illustrates the same. I'll just allude to it briefly. Initially, there is a homeostatic set point, whereby in a normal person, there's equilibrium, there's a normal set point, and it's stable. But when he starts taking drugs, it leads to a allostasis and a huge allostatic load. And hereby you see that this wave keeps going down. And there's a allostatic set point which keeps going down and down, depending on the kind of individual vulnerability factors and the stage of addiction. So this is what I really wanted to highlight, is that there is huge allostatic load which is made on the individual's brain, put on the individual's brain when he starts taking a particular substance. So before we actually proceed ahead, a little bit about terminologies, because we'll be using these terminologies, and many people, it's better that they understand what these terminologies actually mean, and so that we are talking on the same page. So impulsivity, and these are definitions which are convenient for us, and these are not exclusive definitions by any chance. So impulsivity is a predisposition towards rapid, unplanned reactions to internal and external stimuli without regard to negative consequences. Compulsivity, and I'll just read them out so that we can just understand them. Compulsivity would be a perseverative, repetitive action that are excessive and inappropriate. And as I said earlier, individuals move from impulsivity to compulsivity during this drug stage, during the dependent cycle. However, both of them tend to coexist in a single person. What is reward? A reward is any event that increases the possibility of a response with a positive hedonic component. Hedonic meaning pleasurable component. Incentive salience can be defined as a motivation for rewards derived from one's own physiological and previously learned association. So a value which is given to a particular reward can be called as incentive salience. Conditioning, and we have learned about conditioning in psychology, but here we are talking about neurologically how conditioning occurs, and it is the response of previously neutral stimuli to which drugs become paired. So, as for example, you see a syringe, you are reminded of taking heroin. You go to a party, someone invites you to a party, and you think of taking alcohol. So these are actually neutral stimuli. The injection, the syringe, the party, they are all neutral stimuli. But then when they get started getting paired with the drug, they become conditioned to elicit cues. What about opponent processes? Opponent processes means that every single reward can actually elicit an opposite process in the cellular mechanisms. And this is very important in case of substance use. We know about neuroplasticity, we know about allostasis and allostatic load. So I'm not going to go into details, but just for the sake of completion, I have mentioned these definitions. So what really happens? These are other important things in context of drug addiction, which is interoceptive awareness. See, whenever we take a drug or any person who is dependent takes a drug, they have this ability to sense and interpret and respond to internal body signals like anything. I mean, pain, breathing, temperature, hunger, stress, anything. And it becomes a signal for them to start taking a drug. We know about executive functions. Hyperkatifia is defined as a constellation of negative or motivation, negative emotional signs such as dysphoria, anxiety, depression. Hyperalgesia is an increased sensitivity to pain, and hypohedonia is a decreased ability to experience pleasure. So some of these terminologies are going to be used uh, uh, repeatedly in this presentation, but we should know what we are talking about so that you can understand when I discuss about them. So what really happens? Intoxicating doses of alcohol and drugs release dopamine and opioid peptides, principally in the ventral striatum. And not only about release of dopamine, it is how fast it is and how steep it is. It is extremely important that dopamine is actually continuously released in the ventral striatum. But drugs tend to do it at a faster and steeper rate. This is actually modulated by other neurotransmitters such as glutamate, serotonin, acetylcholine, endocannabinoids. But what is important to understand is that every single drug with addiction potential tends to increase dopamine in the ventral tegmental area, either directly or indirectly. And the initial action depends on the unique pharmacology of every single drug, which is different. So again, for simplicity's sake, this is the dopamine system in our brain. The ventral tegmental area sends inputs to the prefrontal cortex and the nucleus accumbens, and to the substantia nigra, which then sends it to the dorsal striatum. This is again not an exclusive dopamine system in the brain, but for our purposes, this is enough. So this diagram, this busy little diagram, again shows that all our different drugs such as opiates, alcohol, nicotine, cannabinoids, etc., tend to increase dopamine, either directly, which I mentioned earlier, or indirectly, depending on the unique pharmacology. But the end result tends to be an increase in dopamine in the ventral tegmental area. If you look at the right side, you see the different mechanisms by which they tend to increase dopamine. And you can see the arrow later on, whereby there's an arrow which points upwards and there's an increase in dopamine. Again, different mechanisms. Again, as I said, we are not going to discuss every single drug. It is simply impossible to do so in this particular talk. So this is the summary of what happens during the binge intoxication stage. The withdrawal or negative affect stage consists of key motivational elements such as chronic irritability, withdrawal, which we see, emotional pain, malaise, dysphoria, alexithymia, states of stress, and loss of motivation for natural rewards. Again, please pay attention. Loss of motivation for natural rewards the drug reward tends to take over the natural rewards. So when we actually tell our patients, when this is something which we see usually, and we see you go, we tell them to go for sports, exercise, or religious functions or something like that, they tend to feel less, they find those activities less rewarding as compared to drugs. It is characterized by elevations of reward thresholds, that is a decreased in reward during withdrawal, and they are highly correlated to escalation of drug intake. Because there is less reward, which they feel continuously, they tend to increase the drug intake during this phase. And there is an increase in stress or anxiety-like responses that occur that contribute greatly to the malaise or protracted abstinence. We must not minimize what the point I want to stress is that we must not minimize the stage of withdrawal or negative affect. Actually, we tend to minimize it. We don't treat it adequately without understanding that it is an extremely distressing, extremely dysphoric phase, which can last for weeks to months. And unless we deal with it properly, we are actually leading the patients to relapse. What does this involve? This involves two kinds of neuroadaptations. One is called within system and other is between system neuroadaptations. And I'll just briefly allude to them, not going into too much of detail. But what happens when a person takes a drug, and you know about opponent processes, which I talked about earlier, the primary cellular response which occurs when a person takes a drug, there is a neutralizing effect which tends to happen in the cellular response to try to neutralize the effect of the drug. So what happens is that once the drug is removed, these neutralizing effects tend to persist over a period of time, leading to withdrawal either in the acute stage or even in the protracted stage because of neuroadaptation. So the simple act of taking a drug itself tends to elicit certain other neural responses in the at the cellular level, which can cause withdrawal or at acute stage and even in the protracted and the long-term stage. And generally, it involves a decrease in dopaminergic and serotonergic transmission and increase in opioid receptor sensitivity, especially during opioid withdrawal. Thus, a decrease in reward system, sorry, just a decrease in reward system function might persist in the long term and in the form of changes that contribute to acute withdrawal and protracted abstinence, and could also explain the loss of interest in normal drug rewards. So a person loses interest in not just the non-drug rewards, but other things such, interest, because he tends to escalate the drug rewards, but he also tends to lose interest in the normal non-drug rewards. And what is between system neuroadaptation? When you take a drug, one is that the system tries to neutralize the effect of the drug. The second thing which happens is that it engages other neurochemical systems, which again tend to neutralize the effect of the drug. And usually what this happens is that there is a dysregulation of the stress system to neutralize the effect of the drug. So the HPA axis and the brain stress system mediated by corticotropin releasing hormone are usually engaged when a person takes a drug. And these are recruited in the extended amygdala and lead to negative emotional state. Again, so one within system tends to neutralize the effect of the drug in the same system, and between system in which the effect of the drug tends to be neutralized by engaging other stress systems, usually the stress system. And this concept of anti-reward was then developed. So you see what happens in normal biological systems, as we know, there's a feedback loop, and we tend to limit any kind of effect so that it doesn't go out of hand. And these opponent processes that are a general feature of all biological systems also tend to limit reward. We can't have unlimited reward for everything, and you can't keep having a drug every time, and there can be unlimited reward that the person keeps experiencing at every point of the addiction cycle. So there is something which occurs which tends to neutralize that kind of an effect. So the combination of decrease in reward function and increase in stress function in the motivational systems of ventral striatum, extended amygdala, and habenula, which is again involved in anti-reward, becomes a powerful trigger for negative reinforcement that drives addiction. So as we have seen earlier, there's a decrease in reward. When you continuously take a drug, it doesn't give you the same amount of reward. There's an increase in stress function in this particular stage in the different areas like ventral striatum, extended amygdala, and habenula, which tends to then drive addiction as an automatic behavior. When I say an automatic behavior, it means, for example, we are driving a car. Initially, when we are driving a car, we need to know where the gear is. We need to know the acceleration. We need to know, we'll put on the seat belt, and we need to know the speed limits, etc., which lane to drive in. But after a while, it becomes an automatic behavior. So generally, initially, when the drug is taken, a similar thing happens. Initially, you go search for a drug, you take the drug, you experience the rewarding effects. But eventually, as the dependence progresses, it becomes an automatic behavior. You receive a message from a friend, automatically you go and take a drug. You don't even think about the consequences. You are informed of a party, you automatically go to a party without thinking whether you're dependent or not. So that kind of thing becomes an automatic behavior, which is mediated by the striatum. So this again is again a schematic diagram to recapitulate what I was saying. There is a decrease in dopamine and decrease in opioid peptides on the A side, as you can see. We are not going into the other details. There's a decrease in anti-stress neurotransmitters and an increase in stress neurotransmitters. So the underactivation of anti-stress systems and an increase in stress neurotransmitters plus a decrease in reward tends to drive this phase. So this is just a summary of what I was already saying. And the consequence of all of this is that the individual tends to misregulate by taking more of the drug because it tends to relieve the negative emotional symptoms of withdrawal. So it tries to take the drug to get relief. And then that cycle keeps perpetuating. What about the third stage? The third stage is what is called as preoccupational anticipation stage. And it is one of key elements which is known to cause relapse. It's been linked to the construct of craving, but craving itself does not always correlate with relapse. And we know that clinically. A person may experience craving, but it's not necessary that he will actually go and take a drug. So it's like, for example, a diabetic going to a sweet shop, he may experience craving for sweets, but he may not necessarily go and actually partake that particular sweet, knowing that it is harmful for him. So craving is one part, translating it into action is another issue altogether. Executive control over incentive salience is essential to maintain goal-directed behavior. So any goal-directed behavior, we have to have control over any kind of goal-directed behavior. You want to drive a car, you want to drive it fast, but your brain tells you not to drive beyond 60 or 65, which is the speed limit. So we maintain some degree of control over that driving speed. And the prefrontal cortex is actually in a good position to regulate this incentive salience and conditioned responses. And it sends glutamatergic projections directly to the mesocortical dopamine ventral tegmental area, thus exerting excitatory control. It also sends signals to the caudate and ventral striatum to modulate control over the striatal pallidal thalamocortical system, that is, control over certain motor activities, etc. So the prefrontal cortex is really actually very importantly involved in different kinds of executive controls. Now, these are the different kinds of areas of the prefrontal cortex. Again, not going into detail, but what I want to highlight is that they're involved in self-controlled behavior, monitoring, motivation, learning and memory, decision making, etc. So different areas of the prefrontal cortex involved in different control mechanisms. So what happens is that cue-induced craving produces activation of the prefrontal cortex. And this is usually mediated by glutamate. But in drug-addicted patients and drug-dependent patients, there are deficits of executive function. And this is reflected by decreases in frontal cortex cortical functioning that interferes with decision-making, self-regulation, inhibitory control, and working memory. So, coupled with the fact that they experience a lot of dysphoria during the withdrawal stage, there are already present, there's a presence of deficits in the executive function. So they are not able to actually control their behavior of taking drugs. So their decision-making, their self-regulation, their inhibitory control, etc. is all dysregulated. And the cravings are also mediated with by the insula. So the insula, what happens is that the interoceptive functions, that is, which we discussed earlier, the signals which come from inside the body, it integrates the autonomic and visceral functions and information and motivation. It provides conscious awareness of these urges. So when you start getting these urges, the prefrontal cortex is unable to actually take a decision of not taking the drug. So you can see there are multiple kinds of dysregulations and multiple systems in a person who is dependent on drugs. So in general, just to summarize again, so that we get the main points, the prefrontal dysfunction, cortex dysfunction can lead to a loss of inhibitory control, that may manifest as increased impulsivity and heightened stress reactivity. For example, as I said earlier, you receive a ping from a patient, from a friend, and you immediately go and start taking a drug. So that's heightened impulsivity. You don't even think about whether you're dependent or not. Heightened stress reactivity. Your father shouts at you. He must have shouted at you 1,000 times, but that itself becomes a reason for taking the drug. I have seen patients, so many patients of mine, they when I ask them why they have relapsed, kal fever ho gaya tha mujhe 108, so I thought taking a drug will immediately provide me relief. Fever has got no connection with taking the drug, but then that's how they tend to react to internal and external stimuli. There is a change in attentional bias resulting from altered PFC function. So we tend to start focusing on that more, the drug and its related cues, more than other natural rewards. So there is an attentional bias with a loss of inhibitory control, and of course, finally, leading to impaired decision making. So our decision making capacity itself tends to be impaired. And this unfortunately works not only in while taking drugs, but also other aspects of life, which we see commonly. I mean, this is something which we clinically see commonly in many of our patients. So this is something which I wanted to highlight. Many of us don't think of how drug addiction and memory systems are correlated and how they are engaged. And again, I thought this is an opportunity for us to think about this, because many people think that drug addiction is partly because of dysregulation of memory systems. So I'll just highlight this point a little bit. So drugs of abuse can positively affect all factors such as of learning, and our brains keep learning, and it's a continuous process from birth to death. We learn about different kinds of things all the time. And the drugs actually induce alterations in associative learning, translating memory into action and habit formation. And generally speaking, the hippocampus, the dorsal striatum, and amygdala, all three parts of the brain are involved in this memory system. And the hippocampus tends to mediate a cognitive spatial form of memory. The dorsal stratum tends to mediate a stimulus response habit memory. When I talked about driving, habit memory, it becomes automatic. The amygdala mediates a stimulus affect associative relationship. It engages the emotional arousal and other types of memory generally also. And drugs can modulate memory function in each of these brain regions. So what happens? Because of a dysregulation, all of these three areas of hippocampus, dorsal stratum, and amygdala, these drugs continue and enhance their own self-administration because the memories are so strong that they keep coming back. And this is this is commonly clinically seen is that acquisition, consolidation, and retrieval of memory in drug-dependent patients is much, much stronger than in other patients persons who are non-drug dependent because of a strong dysregulation of the memory systems. Generally, what happens is that when you retrieve an information from long-term storage, it becomes destabilized and you keep, and we see this normally, we remember some things, we don't remember some things. We have visited a place a few years back, we may remember some of these things, maybe a vacation or something with our family or something like that. And we may remember some things, we may not remember some things. But when it comes to drugs, what happens is that these memories tend to become reconsolidated at a stronger level as compared to other normal memories. And that's why what you see is that patients who are, say, abstinent for weeks to months or even years, 2, 3, 4 years later, tend to suddenly relapse with a single dose of a drug. So the memories tend to come back fast. The already dysregulated and neuroadaptive systems are there. The single dose of drug tends to invoke reward in some of the patients, and some of the patients may take some more time. So it's of course not 1:1 kind of correlation, but in some patients it may take more time. But what happens is that the memories come back so strongly that they are very, very difficult to disrupt. So every time a drug memory, associated memory is retrieved and reconsolidated into the long-term memory, the process may become much, much stronger, resulting in progressively more drug use memories with repeated use. This is what happens in advanced stages of dependence, not in the early stages. So this is again a very important process which many people don't focus on. Again, this is just again a schematic diagram of what I've highlighted earlier about amygdala and caudate, that is the incentive, the habit, and the declarative memory, and how they are involved in the process of addiction. Again, I'll not go into detail because I've already explained many of these things. So a few slides before I end. So what does all this actually mean? And we've discussed so many neurotransmitters and circuits and everything. See, for every individual, there is a go system and there is a stop system. The go system, depending on individual vulnerabilities, your genetics, epigenetics, and other vulnerabilities in the neurological system, the go system will drive craving and engage habits, usually via the basal ganglia, and the signaling pathways that contribute to the transition from moderate to uncontrolled excessive drug use can be called as go pathways. Addiction thus can be thought of a maladaptive form of learning and memory, and many of these go pathways involve synaptic plasticity, learning, and memory. On the contrary, the stop system is there. This could control the incentive value of choices, that is the drug, and suppression of affective and negative emotional signals. And thus, a stop system will inhibit the go craving system and the stress system. So depending on the balance which is there, whether the go system is more dominant or the stop system is more dominant, an individual may tend to become, continue to take drugs, or may continue to, or may just stop at some point of time. So the endogenous pathways that work in the opposite direction to the goal pathways and thus promote against the development of dependence and keep drug and alcohol intake in moderation. So it's not that everybody who tends to take a substance tends to become dependent. It is actually, you will be surprised to know that it is quite a low percentage. For example, for alcohol, it's about 7 to 9%. For psychedelics, it's much lower, and cannabinoids is much lower. For heroin, it's about 30 to 40%. So you see, there's a large proportion of patients who don't tend to get dependent on drugs. And this is something which is we must realize that individual vulnerabilities play such a strong role in determining whether a person will tend to become dependent or not. So as I said, I like simple diagrams, and we return to this diagram, which we saw in the first couple of slides or so. So you see three processes: the reward processes, mediated by the nucleus accumbens and the ventral tegmental area. Again, you see the multiple feedback loops and how the stress-related systems are mediated by amygdala, habenula, hippocampus, the decision-making system by the prefrontal cortex, the insula, which I described earlier, which is involved in introspection and interoceptive awareness, the dorsal striatum, which is involved in habit, in motor activities and habituation, drive and action, how they correlate with each other, right from the action of taking the first dose of the drug to finally a state of dependence, how they mediate, and there's a feedback loop between them, and they lead to a state of dependence. Again, as I said, this is a simplistic diagram. Nothing. This is not complete. There are many more different systems which are involved. But if we don't take this kind of message back, and we will just tend to confuse ourselves, and that is not my objective today. So there are three things. There is incentive salience or reward. There are executive function deficits. There is a deficit of reward and increase of stress. Just remember these three things during these three stages. So again, this is a global kind of a summary which I wanted to present. And it would be prudent, important if you can remember these three important aspects. But there are so many outstanding questions. How do specific levels of drug-induced adaptation interact? We still don't know. And how do they actually lead to complex behavioral changes? Again, there's a lot of speculation, but we still don't know the exact mechanisms. Which are the molecular pathways and circuits that could serve as the most promising potential therapeutic targets? Because finally, understanding all of these circuits and pathways is important only if we can actually develop some treatments. And how can we develop these kind of treatments? Again, a lot of understanding needs to be done here. Which mechanisms determine individual vulnerability? We know it's a polygenic disorder, but how do individual genes which are involved in it can actually drive both addiction and can prove to be resilient to production of dependence? So we still don't know about these individual genes. Are there additional currently unknown variants that confer susceptibility or resilience against developing problem drug use or issue? So these are many unanswered questions currently when we discuss about neurobiology of drug addiction. So finally, substance use disorders are complex multi-stage diseases in three major neurocircuits, in three domains, as I said earlier. And of course, as with every single disorder, and probably molecular genetic mediation and epigenetic changes in these same circuits provide vulnerabilities to addiction, increase susceptibility to environmental risk factors, and thus also provide us an opportunity to develop novel treatments and maybe even resilience to relapse. Thank you.
Dr. Ajita, can you take up the questions? Unmute yourself.
Hello, sir.
Sir, there are some in the chat box which if Dr. Mohan can just,
Sir, can we equate addiction and reading? Can a person who is addicted?
Just a moment, just a moment, just a moment. Don't
Someone
check
was-
in between. We'll give you the platform. Let Ajita take the questions already in the chat box.
Thank you, Dr. Mohan. That was an excellent presentation, simplified a lot of complicated concepts. So we have many questions in the chat box, many compliments, of course. So how does each substance induce different emotional and affective states when all ultimately act to enhance dopamine in the ventral tegmental area? This is from
So every drug has its own unique pharmacology. As I said in the beginning itself, that it's just because every drug tends to increase dopamine doesn't mean that it does not interact with other neurotransmitter systems. But unfortunately, it is not possible for me to discuss every single drug and how it tends to interact with other neurotransmitters. But that is how it happens. So there are drugs which can elicit strong negative emotional affective states such as opioids and alcohol, but there are others which may not do. For example, psychedelics, even cannabinoids, for example, they don't tend to increase the negative affective emotional stimuli as much as probably heroin or alcohol does. So it depends on the unique pharmacology of the particular drug in question.
how this, yeah, thank you. How the substance affects the memory system so much? Why consolidation and recall is stronger? What is special in the substances? Why steep rise of dopamine only?
Okay. So
Sarkar.
how does the substance affect? The substances tend to affect because there are already pre-existing deficits in the memory systems and executive functions already present in the and this has been shown repeatedly through preclinical and clinical studies in all the areas of these brain where memory is encoded. So there are already pre-existing substances, and this is what has to be understood is that when you have often read about how brains hijack these systems. I mean, sorry, drugs hijack these systems, brain system. That is what happens. The drugs, because of their pharmacology and effect on the neural systems, tend to hijack these memory systems. And because of pre-existing deficits which are already there, they tend to actually affect them, and they bring back these memories at a much stronger level as compared to probably what we normally experience in people who are non-dependent. What is special about these substances? Nothing special really. It is just that a particular chemical tends to act in a particular manner. Especially, nothing special really, I would say, except that the fact is that they tend to be powerful stimulants of certain systems.
Yeah. So thank you. Now, two questions related to treatment. I thought you were not wanting to discuss treatment. One is how this knowledge translates to choose best treatment option and whether methylphenidate will help because of PFC and attentional bias.
Okay. How does knowledge translate to choose the best treatment option for an individual? The purpose of discussing this, having this particular talk is to show how in different ways that addiction actually develops or dependence actually develops. So you have the binge intoxication, the affect or withdrawal or affect stage, and the preoccupation or craving stage that we had anticipation stage that I discussed. All these three stages provides you an opportunity to mediate or intervene in all of these three stages, depending on the kind of symptomatology that a patient may have. So a patient who has experiences a lot of stress, a lot of anxiety, you may tend to use different kinds of medication. A person who's got a lot of craving, but not enough, I mean, high levels of stress or anxiety or dysphoria, use different kind of medication. You may use different kind of medications to attenuate drug reward. So you have three different kind of circuits, and you can actually mediate and use multiple drugs at times, rather than just focusing on one particular drug and say one is not effective for a particular person, and then you stop and say, oh, ye to relapse ho jata hai bar bar. But you can actually use multiple drugs which can target multiple neurotransmitter systems or multiple circuits. So this is how it translates. This is the basic use of understanding of these circuits in a translational sense. And next question was
Methylphenidate.
How does methylphenidate help in the attentional bias?
Yeah,
Okay.
because okay, regarding TFC and attentional bias, is this related to comorbid or underlying ADHD traits? And does this mean that methylphenidate can have a key role in all addictions?
Methylphenidate can have a key role in addictions which tend to have a strong impulsivity component. There is no doubt about that. In my practice, actually, I tend to use a lot of methylphenidate is not easily available, unfortunately. So atomoxetine is my go-to medication, but I use it very, very frequently with patients I know, especially younger patients who have a strong impulsivity component, and I tend to use that. The assessment of any patient of drug addiction involves assessment of vulnerabilities. Without that, just assessing what substance is being used is worthless, I would say, practically. Unless you treat the vulnerabilities and comorbidities, you are just making a patient prone to relapse. And ADHD or impulsivity, and please understand, you don't have to have ADHD per se. Even if symptoms are present, attentional symptoms, distraction, or even hyperactivity, not even to the level of ADHD, they can make a person prone to use of substance. So you must treat it adequately. So methylphenidate, not necessarily, but any kind of medication which will reduce impulsivity can help.
Do we have time for more?
Yeah. Carry on.
Okay. So this there are interesting about, I think we're diverting here, but two questions. One is Dr. Usmania, does a workaholic also stimulate same biological circuits, and how this addiction can be reduced?
So first of all, as a workaholic and addict is a question. I mean, in some societies, maybe you might actually give him a promotion and give him a ESOP or stock options. So probably in those conditions, I don't know whether workaholic may be a addict or not. But what I understand from your point is that the process of addiction continues. So whether he's a workaholic or he tends to do has other behavioral addictions, depending on the context, yes, it will actually stimulate the same brain circuits. How can it be reduced? Maybe pharmacologically, maybe behaviorally, but again, it depends on so many other factors, or whether in the context of that person, it is an addiction or not. It's very, very difficult to determine, because for one, a person may be a workaholic, for the other person, he may be just working hard. So it's a fine line actually. But a simple answer is that yes, same biological circuits are stimulated.
The next we have is, how does endocrinology play a role in this circuit? Is there an endocrinal intervention which can help?
So a lot of these stress systems are dysregulated and are engaged during this process of dependency. So apart from endocrinology, also in inflammatory systems tend to play a role. But I have not come across a specific endocrinal intervention that may help. Although CRF antagonists and HP antagonists I mean, CRF antagonists have been used and many other kinds of different such agents have been used, but they have not been found to be actually clinically relevant because of so many broad systems that are engaged, that to use a particular single drug and expect it to reduce addiction, it has not really worked. Even in preclinical studies, in some studies, they have helped in reducing dependence and some they have not. But at this point of time, no recommended medication is there.
Similarly, one or two is how much these things are true for behavioral addiction.
So, as I have
Maybe the-
answered earlier, similar systems, similar engagements, similar circuits. The only difference is that it's a behavior and not a chemical agent. When it comes to a chemical agent, it is not just the processes which are common to behavioral addictions, but it is also the unique pharmacology of the drug which makes a difference. So that is a slight difference between behavioral and a drug substance addiction. The unique pharmacology of the drug itself plays a role, which is not true for all behavioral addictions, but the processes tend to remain similar, if not exactly the same.
Dr. Dhananjay has asked about use of N-acetylcysteine.
Yeah, N-acetylcysteine, mixed results. Some useful, some not, used in cannabinoids. And I think nicotine also, with nothing positive, nothing negative, but can be used. But nothing, I mean, to rave about. Rave not in the context of drugs, but rave.
Hello, sir. Sir, reading as an addiction in voracious readers, does the same neural circuit play the role?
Pardon?
Reading
Sir,
as
some
addiction in voracious reader.
Voracious eaters. Voracious eaters, voracious tennis players, voracious gamers, voracious gamblers, voracious stealers. So society tends to determine many of these things. The process tends to remain the same. Voracious eaters, you may like voracious eaters and you may hate voracious gamblers, but the process tends to remain the same. A society determines whether you like it or you don't like it. And unfortunately, the context tends to matter here. But as I said, because of this, any addictive compulsive activity would tend to engage the same systems.
thank you, sir. Thank you so much.
Dr. Ajita, there is a question from Dr. Shekhar Yadav. Few pointers to tell caregivers of patient of drug dependence, to tell them about its neurobiology, which is making him or her drink, which can promote empathy towards patient.
So, you see, not in the context of this talk, but it's such a very, very important question. And it is important to emphasize the biological underpinning of addiction. Because many of the times our patients themselves and their relatives tend to misunderstand the fact that they continue to take a drug because they want to. So there is a difference between wanting and needing. They may not want to, but they may need to. And because of this need, they continue to take this drug. So if you're not able to delineate this difference between wanting to, that is a conscious decision of wanting to take a drug, versus the needing to remove them from this misery of an affective state, negative affective state, and the craving which is present continuously over a period of time, I think that kind of difference needs to be delineated. And it also tends to reduce the distress of our caregivers too. Because they understand, once they understand that it's not that the person wants to take the drug for enjoyment purposes, but it is an inherent biological process which is happening. And therefore, we must help him to reduce that. that tends to reduce the distress of the caregivers too. So this is a very, very important question, maybe not in the context of our talk, but I think this is what we can do. And promoting empathy, supportiveness is very, very important. And there are no two things about this. Support from caregivers, because they're the closest members who are with the patient, they can actually tend to make and or break the situation many of the times. And we've seen supportive family members who can get a person out of this dependence many of the times.
Dr. Malai, can you chip in? You have not opened up your session
Sir,
today at all.
what is the difference between physical dependence and psychological dependence?
So physical dependence basically means the physical withdrawal symptoms which occur generally. I mean, whether when it's alcohol, it may be tremors or other kind of things, or opioids, it could be twitching and things. Psychological dependence basically means the mental processes which occur in the brain, which usually the negative processes which occur in the brain during the withdrawal stage, which tend to promote dependence. So again, it really has no meaning, much meaning. I would say it doesn't have clinically much meaning of differentiating between physical and psychological dependence, really, because the same processes in the brain tend to cause some somatic symptoms and some other so-called psychological symptoms. So when you treat them both. You don't treat them separately. So it's just a kind of nitpicking, I would say, to an extent.
Yeah, Dr. Malai, if you can chip in.
Yeah. Thank you, Dr. Ashwin. It was a very nice session, very lucid. All the points that we would have liked people to know about the basics of addiction from the neuroscience perspective. You made a very nice attempt to make it easy for us to understand. I think the treatment targets and what would be the practical relevance of things would be a matter of the second session. What I would like to just kind of repeat maybe in different words is regarding the questions that have been asked. One thing is that all of us have the same processes inbuilt in us, and that is why we are able to function. We are able to function as human beings, and we are able to do things better. We are able to sustain doing things over a lifetime, probably learn new things, is because we have these systems in place. All the three things, all the three compartments, or all the three parts that Dr. Ashwin talked about. One is the salience, one is the stress circuit, and second is the cognitive impairment or executive dysfunction. It works in all of us, but not in the impaired fashion or not in an abnormal way. And that is why we are able to sustain activities which are over a period of time without this being detrimental to us. So if somebody had asked about reading, well, reading or any activity that we learn and that we practice over years, even the art and science of practicing psychiatry, forget reading, what we are doing as a profession is learned. The first basis of learning is whether something interests us, whether something gives us some kind of pleasure. And that is where the salience kicks in. Once we have that salience in place, then it is going to modify certain behaviors and make them repetitive more or repetitive less. So we practice psychiatry, we learn psychiatry, we read over time, and these things give us certain value. Now, the point at which they become addictions, as in disorders, is when there is a loss of control, when there are detrimental effects, when these things become compulsive. So any behavior that we have as human beings can become or can fall in this slot and become problematic. So the mechanisms are same, the circuits are same. But in people who have got addiction as a disorder, we are talking here about disorders. There are certain things which are out of the normal experience and the normal functioning when it comes to circuits. And then there are there's a lot of background to that, which would come from genetics and early childhood experiences and development and so on and so forth. So when we are looking at addictions, we take, we tend to focus only on substances. But substances are pretty discrete. They're one agent, and then we can, kind of trace the pathway of this agent in the human brain and how it affects systems and so on. but even complex behaviors will follow the same kind of pattern. So what we should be interested as psychiatrists is not addiction as in substance use disorders, but addiction as a process, how this process operates in individuals. And this may be seen with other psychiatric disorders also. When we talk of addictions, as Dr. Mohan mentioned, as impulsive and then becoming compulsive. So whether those compulsive behaviors that we see in obsessive compulsive patients also fall on a similar spectrum. That is, they keep on doing that activity because if they do not, then they will have that anxiety. Very simply put. So this kind of behaviors are not only related to substances, but to any kind of human behaviors which can become excessive, which can become detrimental, and for which there is a loss of control. So we need to kind of broaden our perspective of what addiction is, not limiting to substances only, but covering a wide variety of things that we will see. So we should not be surprised when somebody talks about behavioral addiction or this addiction or that, but we need to see what is it. I mean, reading, yes, we can read. Now, if at the cost of reading a lot of other things are happening, then maybe it is a problematic thing. Otherwise, it is not. And more importantly, when it comes to addiction, the social aspects of addiction kind of govern what is problematic or not. We give value judgments. This is good, this is bad. And that creates more problems, not only for the person who is suffering from addictions, but for also for us to treat. So not only, I mean, we have a basic kind of a biological perspective or a biological background, and on top of that, there are these social labels which can worsen our way of looking at patients and including instituting adequate treatments also. So I think, in brief, very nice presentation and a lot of nice take-home messages. I hope everybody has enjoyed today's session, and then the next session would be pretty much interesting on the same lines.
Dr. Ajita, do you have anything to add on?
Yeah, no, so there are some more questions. I had one. Can I ask?
Please.
We have these various types of dependence patterns, especially in alcohol. Call them alpha, beta, gamma, etc. Or some of them would have blackouts. So is this symptom related also? To have different areas of the brain involved with different presentation?
So I'll confess I'm not aware of alpha, beta, gamma kinds of dependence. So I will not be able to answer that particular part of this thing. But yes, blackouts, degree of intoxication, degree of dependence, binging, all of them are patterns depending on individual kind of vulnerabilities. So yes, in that context, I would say that no substance use disordered person, it's not a homogeneous population. It's a very heterogeneous population. Like a person, depression or any other kind of an illness, they're heterogeneous populations. So there are so many multiple factors which are working in conjunction with each other that we can't expect that a particular phenotype will be expressed in that person. So we see multiple people with multiple kind of expressions, even with a particular drug. So that's how I can answer, though I'm not aware of this alpha, beta, gamma. Unfortunately, I've somehow not read about it.
Maybe a very old concept. Okay.
Yeah.
Dr.
Thank
Malay, do you have to add anything on that?
Yeah. So the only explanation could be this, that like all our disorders where, the phenotypic presentations are different, but they come under the same heading. So depression will have so many types of variations. Psychosis will have so many types of variations. So even addictions will have different kinds of variations depending on the background, depending on all the things that we studied today. So for somebody who has got, let's say, a more robust genetic makeup, will have less salience towards alcohol, for example, and might not have that same pattern, which is a daily use. Because we talk not only of a longitudinal pathway or a longitudinal trajectory, but also the mechanisms and the feedbacks that happen dynamically. So when these opponent processes are happening, some things might be controlled well, some things might be controlled for a period of time. So you will have somebody who is okay for a longer period of time, but then that might not be enough. That might lead to a binge kind of a pattern. So probably this is how we can hypothesize. It's a hypothesis, and this whole thing, this whole model is how we are looking at it, and this model is open to a lot of other inputs, which we have just kind of scratched the framework. So probably that is the reason. So in any individual, there would be factors which would be, we talk of abnormal genetics and epigenetics and all. This would be the vulnerability or the susceptibility factors, but there would be some things in certain individuals which would be more protective, which would be more favorable towards a better outcome or a less problematic pattern, things like that. So we have, as in psychosis, we have somebody who has one episode in life and then nothing happens. And then there are some who will keep on having a progressively downhill course, whatever we do. So probably these are the kind of variations related to the basic functioning of how this, to the basics of how these circuits function, because all these circuits are not uniformly not working well in all patients. Even in the same individual, some circuits would probably overtake or work better than the other. So maybe the control is better, or the loss of control is problematic that way.
That's it, Ajita.
Thank you. Thank you so much, Dr. Mohan. That was an excellent presentation. And again, as I say, complicated concepts simplified, and the diagrams really, I think, excellent. So, and thank you again.
So
Thank you to the
I'll just take
Psychiatric
this.
Society and Dr. Rajkumar for inviting me to chair.
Yeah, I'll just
Thank
take this last question which is there. That is that I'm sure you're aware that Government of India has called this Nasha Mukt Bharat in terms of increasing non-drug rewards and reducing stressors. I think Nasha Mukt Bharat consists of only removing all kinds of illicit drugs from the country. That is actually really impossible. Unless you remove all the receptors in our brain for all the drugs, that is never going to be possible. And be reminded of this fact that all these receptors and all these systems are required for normal functioning.
Normal functioning.
So this is a good political slogan, but has no real neurobiological meaning really in our lives. So thank you so much, Dr. Ajita and Dr. Rajkumar, Malay, and everybody else. Thank you for providing me this opportunity. I hand over to Dr. Rajkumar. Thank you so much.
Thank you, Dr. Ajita, for chairing the session. Thank you, Dr. Mohan, for an excellent and lucid presentation, and to Dr. Malay for his inputs always. And to all my friends who have stayed so late with us. We'll come back to you again in a fortnight, where Dr. Ashwin will again continue the management of addictions. Till then, goodbye, good night. Thanks to Alchem Laboratories, the CNS division, who are the knowledge partners. Good night to all of you.
Thank you.
Thank you.
Thank
Good
you.
night.